We described the influenza life cycle and the mechanism of action of endonuclease and neuraminidase inhibitors. We distinguish between influenza, rhinosinusitis, pharyngitis, and other acute respiratory illnesses. Now, given a patient with acute influenza, design a therapeutic regimen. The goals of influenza treatment include control of symptoms, decrease of productivity loss at work or school, prevention of further complication, and prevention of infection spread. Pharmacotherapy of influenza primarily revolves around neuraminidase inhibitors. We have 3 neuraminidase inhibitors available on the market: oseltamivir, zanamivir, and pramivir. Both the 2011 CDC guidelines and the 2019 IDSA guidelines for influenza recommend neuraminidase inhibitors. Therapy with adamantane is no longer recommended because the currently circulating influenza A viruses are uniformly resistant to these agents. Now, by the time endonuclease inhibitor baloxavir was approved by the FDA in 2018, the 2019 IDSA guidelines were already finalized. So IDSA does not have any recommendation for baloxavir in these guidelines. It's important to have a few considerations. First of all, most healthy persons with uncomplicated influenza will actually recover completely without therapy. The greatest effect of antiviral therapy is typically seen when therapy is started in the first 24 hours. And no rigorous studies have ever demonstrated a benefit of antiviral therapy once it started after 28 hours or more of symptoms. In persons with severe illness or prolonged viral replication, even late therapy after 48 hours can occasionally be of benefit. However, all robust data are from patients with uncomplicated influenza, not hospitalized patients. Therapy in patients with risk factors for influenza complications has not been evaluated extensively. Only observational studies are available. Now, here are the recommendations that are for the most part the same from IDSA guidelines as well as the CDC guidelines. They both recommend neuraminidase inhibitors as early as possible, even after 48 hours of symptoms, in patients with confirmed or suspected influenza who are hospitalized. So anybody who's hospitalized because of flu, whether confirmed or suspected, they should receive neuraminidase inhibitors. Also, if someone is not hospitalized but they have severe, complicated, or progressive illness, they should receive neuraminidase inhibitor, as well as outpatients who are at risk for influenza complications. And those risk factors are on slide 25. Now, for patients with acute uncomplicated influenza, if they're presenting after 48 hours of symptoms, treatment is not recommended. Now, for those who do present within the first 48 hours for acute uncomplicated influenza, antiviral treatment may be considered. So you don't have to give it to everyone, but they may be considered. And of course, they can also be considered in symptomatic outpatients who are household contacts of persons who are at high risk of developing complications from influenza, or symptomatic healthcare providers such as pharmacists who care for patients who are at high risk for developing complications from influenza. Now, which antiviral should be prescribed? So the IDSA guidelines actually say that clinicians can choose any of the neuraminidase inhibitors, either oral oseltamivir, inhaled zanamivir, or IV pramivir. For uncomplicated influenza, the duration of therapy depends on the agent. So it's 5 days of therapy for either oral oseltamivir or inhaled zanamivir. However, with IV pramivir, it's a single dose. However, these are for uncomplicated patients. You may consider longer duration of antiviral therapy in patients who are immunocompromised or patients requiring hospitalization for severe lower respiratory tract disease.